mute while you sort of...
Hello everyone, thank you for joining and just admitting everyone. Just give it a minute or two while everyone's joining. There's lots of you here, that's fantastic.
I think you're going
can I ask everyone to just check they're on mute? That would be fantastic. It's surprising how much background noise comes through. Okay, so we'll make a start. So for anyone who doesn't know me, I'm Beth. I'm the support nurse at WM UK. And thank you everyone for joining us this evening. It's fantastic to see so many of you here. So we're really lucky to be joined by two fantastic speakers this evening who've kindly given up their free time to come and talk to us. So our first speaker is Professor Diana Greenfield. She's a consultant nurse at Sheffield Teaching Hospital and leads a service for patients living with the late effects of cancer treatment. And we're also joined by Sarah, who's been living with WM for a number of years and is going to be sharing her experiences of managing the late effects of WM and its treatment. So just a bit of housekeeping before we kick off. We're recording this session so that we can put it up on our website for people to watch afterwards. So just be aware that we are recording. As I just said before, if everyone can check they're on mute when they're not speaking, that would be great. And also there'll be plenty of time after Diana and Sarah have finished speaking to ask questions. So you can either write your questions in the chat box for me to read out, or you can raise your hand and I'll call you in at the end. So without further ado, Diana, I think you're kicking us off.
I am indeed. Hello everyone, it's lovely to be here and thank you for asking us to come and join you. So as Beth says, I work in Sheffield and I'm a consultant nurse. Can you see my slides yet?
Yes, we can, yeah.
Are they in screen show?
Yes, they are.
Okay, good. So I work in Sheffield and I'm the professional lead for the late effects service there. I'm definitely not a WM expert, okay? Most of what I know about WM is from being a friend of Sarah's. So, and we have been friends professionally because Sarah is also a senior cancer nurse. So we have known each other. So I know very little. So forgive me on that, but I do lead the late effects service. I haven't got any WMs in my service. So I am just going to just have that disclaimer there and just focus on what I do know and talk to you more generally on late effects and try and do a focus and do you justice. But I'm definitely know that I'm in the company of the experts rather than me talking at you. So I just want to talk about late effects more generally and just start with really with the definition. And there are a couple given on this slide. One from the UK, Macmillan Cancer Support, and one from over the pond, National Cancer Institute. And late effects can be defined through the Macmillan definition, side effects that don't go away. And they can also be side effects that don't happen until months or years after treatment. So late effects is a bit of a funny term, and it's one that's been around for some time, about 50 years or so. I'm not sure it's a great term because it is sometimes a bit misleading because it's about the long-term effects or the effects that come on during treatment or early on that are persistent, as well as very late effects. So it's a bit of a mix of both. And sometimes that can be a bit misleading. So with that in mind, how I do things in my service is really to try and evaluate, because late effects essentially can be as wide as they're tall and any system can be affected. And so we need to think how we operate as a clinician and how we might assess a patient who comes through the door. Any one of you might have a variety of different problems, and you can tell us what the problems, but we actually then need to make an assessment of other things and other risks. So what I normally do is try and think of late effects in terms of functional effects. So that could be as a result of surgery or radiotherapy, such as, for example, lymphedema, physical effects, which I'll come back to, and then psychological or emotional effects, such as mental health issues, PTS syndrome or PTSD, anxiety, and so on. Then coming back to physical, we divide the late effects into malignant and non-malignant. So we do know that somebody with a cancer diagnosis does increase their risk of having a second cancer, not necessarily a recurrence. And that can be for a number of reasons. And then we think about non-malignant, and we can consider those as immune effects. So lowering your immunity, so meaning that you're immunocompromised. And then endocrine effects is very commonly affected by cancer treatments. And then organ specific, such as the lung or the heart or the guts. And so that's generally how we might think of considering an assessment for late effects. And then there are another way of really thinking about it is in terms of ongoing, enduring symptoms such as cancer-related fatigue and cancer-related pain, which are very, very common in all our cancer patients, regardless of their diagnosis, and don't really fit into any system, or, as you probably experienced, not many services either. So that's kind of a general overview of late effects. So who's at risk for late effects more generally? And we know that vulnerable populations are. So those who are very young, who have developing organs. So I actually look after adult survivors of childhood cancer. And this is where most of the evidence and research has been done in survivors of childhood cancer. But of course, other vulnerable populations include the elderly who have aging or senescent organ systems, and frailty is increasingly something that as healthcare professionals we are managing people who have got a cancer diagnosis but may have many other health conditions as well, and are getting older and may not be able to have full strength treatment as a result of aging organs. So those are two vulnerable populations, and other risks for late effects, including the prognosis of the staging of the disease, and the resultant therapy. So, for example, those who need an autologous or an allogeneic transplant is the most intensive treatment, and those will mean that there are considerable risks of late effects. Age at treatment goes with the vulnerable populations as well. Gender, we do see a higher prevalence in women, those who have other comorbid health conditions, those who may have genetic factors, and those who have sort of deleterious lifestyle factors such as smokers. So those are other risks for late effects more generally. So why is it important? Well, as WM, you are a very small proportion of the cancer population, but overall, we're looking at 3 million in the UK of people living with and beyond cancer, and that's increasing all the time. So 3.5 million by the end of the decade, perhaps 4 to 5 million by the following decade. And many more patients are living longer term, maybe not economically active anymore, and having other impacts, and constantly coming back to health resources with additional problems as a result of the disease or the treatment. And it's important because our services really aren't designed for this, and are still old-fashioned, and we're not really being responsive enough. So it is important to understand who our patients are and what problems they've got. So one of the things that Beth and Sarah and I discussed before coming on was an overview of considering the overview of common treatments and associated late effects for WM. And we've listed sort of 5 key ones here on this page, and I don't know whether you can see them and whether they project. But the first one is neuropathy. And I know that Sarah's going to tell us about her experience of that, and many others will probably share. So this is often the most prominent late effect, particularly with treatments like bortezomib. You have to forgive me, it's late in the evening, I've had a long day, and can manifest as tingling or numbness in the hands and feet. Other common treatments associated problems, myelosuppression. So chemotherapy can suppress the bone marrow function, and this may result in anemia and may increase the risk of infection and bleeding problems. Immunosuppression, certain treatments like rituximab can impair the immune system, making patients more susceptible to infections, and they can be low-grade grumbling infections that can just keep bringing down your resilience and just sort of grumbling and just persistent and really impact on your quality of life. Second cancers, we've mentioned that already, but long-term exposure to certain chemotherapy agents can increase the risk of developing other cancers later in life. And usually it's a decade, 2 decades or more after treatments. Fatigue is, as you well know, a common side effect of many cancer treatments and can persist really even after treatment completion, much further down the line. How do we manage and support our cancer patients? And that's one of the developments we want to really see, and that's in the long-term plan, is enabling every patient to have a survivorship care plan. That's what they're called across the pond. It's not a term necessarily used here, but a late effects care plan. Sometimes they're called treatment summaries. This is a suggested schedule for follow-up exams and other tests that you might need for screening in the future. It may well include a list of possible later long-term effects of your treatment, what to look out for, when you should contact your doctor. It should also include some health promotion suggestions and reminders to keep your appointments. Now, this was accessed from the sort of North American idealized care, and we're still aware, even though we've been trying to achieve this for many, many years, that it's still not happening in many places, even though it's in the plan. And that's something that we would really like to improve on. In terms of symptoms and red flags, worsening persistent symptoms, I often say for someone who's had persistent symptoms for more than 2 to 3 weeks, unexplained weight loss, recurrent infections, increased breathlessness, increased propensity of bruising, bleeding, lumps and bumps, skin rashes, or appearance of new moles and lesions as are very common red flags. Monitoring and supportive care. Monitoring regular blood tests are crucial to monitor side effects. Supportive care is the management of side effects that involve medications to manage neuropathy, blood transfusions for anemia, strategies to prevent infections. So that's not the disease itself, but the impact of the disease and the treatments. And then, of course, there's always individual variability. So you will all have your own experiences. And someone with the sort of same stage and the same treatments can have very different responses. And so there's huge variability, and how we look after people needs to be individualized. So what can we do to help you? Well, in my service, what we try and do, and we don't always get it right, is simply to ask you and to listen. And what's concerning you is, and ask you how it's affecting you. It's really important to be able to hear and how we might support you with that. Additionally, we do in our service do a full systems review. That's head to toe review, and these are all the systems listed here. So this is time consuming, but it's important, and some hospital systems don't have the facility to do this, and it does mean we need to allocate more time to each appointment, but it's a thorough review is very important as far as we're concerned. So within our service, we offer a holistic integrated care of people affected by cancer, as a long-term condition, and we just sort of consider how we manage things in 3 different ways. I talk about anticipatory care, and what I mean by that is screening and prevention. So that is considering what treatment somebody's had, what risks they may be at, what common problems are, and screening and looking out for those, supporting people in terms of lifestyle changes and health promotion. So that's a sort of stage 1. Supportive interventions is the next part of the model of care, and that's to consider how we might support someone to adjust to a new level of functioning. So if you have problems or effects on from the treatment or the disease, and it's just a new way of being, that can mean you have to do things differently, function in a different way. It can be process of loss and adjustment, and therapeutic conversations, whether they're with us or whether you need more professional input from psychology or so on, is part of that process. And then finally on here, we do a lot of complex case management for patients who have multiple late effects and problems requiring multiple medical specialties. And we do a sort of central sort of umbrella overseeing and a lot of advocacy there when there's a big burden of appointments and getting through systems where different services don't speak to each other. And we do try and help ease that as much as we can, although we don't always get it right. So lowering risk of second cancer is important for all cancer patients, and particularly for yourselves. And this is the general standard health promotion advice that we give in terms of healthy lifestyle, avoiding smoking, getting to and stay at a healthy weight, physical activity, following a healthy eating pattern, and moderation in alcohol. And then coming back to how we might manage that, in our service, we have what we call a hub and spoke model of care, and that therapeutic conversation when we've listened to your concerns and then we've done our systems review, we put all that into a pot and decide on the priorities. And we may well then make some recommendations in terms of social navigation to voluntary and third sector referrals. We may well make some recommendations for rehabilitation in its broadest sense, including talking therapies or occupational health advice, pain services. And we may well then also refer, dependent on need and the results of our screening investigations, send on to different medical specialties. And that's our hub and spoke model of care. Our service really thinks that embedding research and keeping research close to the patient is absolutely crucial to making sure that our care is contemporaneous, that we are up to date with the most current evidence, that we apply it in practice, and that any new observations then may stimulate new questions, and we're often curious and keep curious, and that keeps us as research active, and there's a sort of cycle of keeping research close to the patient. I realise I might be over my time, so I'm just going to nearly coming to the end. So one example I wanted to give that I discussed with Beth and Sarah in preparation for this, for your group, is some piece of work that we did in Sheffield that really has started small and has stimulated big activity. And that's in the area of late effects within myeloma, which is also, as you're probably aware, a blood cancer that is not considered curable. And patients have multiple lines of treatment and sometimes very intensive treatment. And we got very, very small, modest research funding to do a series of projects. Well, a review of about 30 odd patients, and we looked at various factors, gave full sort of medical review and did it in a research way, and published a series of papers. And on the back of those, we then developed some screening guidelines, which we did with the sort of national group. And it was published in the British Journal of Haematology about 6-7 years ago. And those guidelines for screening and management of late effects in myeloma and its treatment was the most downloaded publication of that year in that journal, and it identified a real need within clinicians to provide this care that we are advocating. Our colleagues in Northern Ireland at another centre actually then implemented that into practice, and then they audited against our guidelines, and they published that at Christmas, and that's the bottom publication that's shown in this slide. And we're delighted to demonstrate through that it showed an immediate improvement in patient care. So you can do things without mega big clinical trials and grants, and it might be that WM, you are a small population, that this is something that you want to see happening. And I'm just presenting here as a possibility for you to think about, to start maybe lobbying or requesting from your clinicians about how they might approach this, because as far as I'm aware, there's nothing available yet. So overall, we're moving to the end now. Thinking about late effects care is an opportunity for more effective management. Planned late effects care can enable proactive self-management. It keeps you in the driving seat. It keeps you more in control. And then it can help reduce clinical crises and subsequent resource use if it's started at the very beginning rather than as afterthought. It can support improved stress and anxiety management. We really aim to optimize your health at a time where you may be unwell, and support people to keep economically active. What we do with late effects is try and detect and manage problems sooner, and hopefully try and communicate that with primary care team, so we have different agreed responsibilities. And ideally, what we want to do long term is reduce and better manage excess morbidity, and certainly reduce the risk of people dying from treatment consequences. But where are we going in the future? So the long-term plan is coming out. Lord Darcy told us about this last year, and it's going to be 3 main shifts coming to the NHS and how we deliver services. We've got to shift from analog to digital, and that's a real opportunity within cancer care to use electronic patient-reported outcome measures. That's what PROMs stand for, to do remote monitoring. We want to shift secondary to primary care. So I'd really like to see some commissioning anticipatory care model for patients who are very medically stable and but have had treatment and just could have some very simple monitoring in primary care rather than keep having to go back to hospitals. And then shifting to preventative care. And I think this is where, if we do have more commission services for late effects, we can pick up and identify problems sooner. Ascend is the name of a workforce education program for nurses, nurses and allied health professionals who work in cancer care. It's a nationally agreed big program, and Sarah and I did contribute to earlier versions of it. And this is really important for all your clinical nurse specialists and any cancer allied health professionals that you see have standardization of education in cancer, which currently doesn't happen. And I've already mentioned my commitment to research and how important that is. So I've gone over a bit, but thank you for listening. This is me, and I think we're going to probably move over. I'll stop sharing, and we'll probably move over to Sarah and then take questions at the end. Is that right, Beth?
Yeah, that's right. Thank you so much. That was fantastic. So over to you, Sarah, when you're ready.
Okay. Yes. Hello, everyone, and welcome, and lovely to be talking to you. I hope you can see my screen now. I'm sort of a colleague of Diana's, but also I'm a specialist in late effects, but from a radiotherapy point of view, and I'm actually a senior nurse and was a clinical academic. And I actually have Waldenstrom's and have had it for a number of years. So I really want to talk about my experience, but also the sort of, not the issues, but the sort of the long process and the long-term effects of Waldenstrom's. And so what I want to do is just break this down into long-term and late effects, a bit like Diana was saying, but also that sort of empowerment through practical skills, which really helped me in terms of improving my health and physical fitness, but also taking my own control, because like many of you, I found that there was very differential approaches to care, and I had to sort of almost take control of my own management and get referrals and stuff like that. So I was diagnosed with Waldenstrom's in 2015, which seems quite a long time ago now. But I'd been treated for 3 years before that for chronic peripheral neuropathy with what's called MGUS, which is the sort of benign peripheral neuropathy. And basically, I used to play hockey, and I suddenly found that I couldn't run anymore, and I was beginning to fall over more, and I kept having accidents and stuff like that. And I was losing sensation in my feet. And it was when I lost a shoe getting on a train, you know, where it falls down the gap, but I suddenly realized there was something seriously wrong. And I was managed by hematology for a few years. And then I was beginning to lose my hands. And as a nurse, it's quite difficult to be clinical if you can't feel the needles and can't actually put syringes together or feel, when you're palpating people. So I was asked to be referred by my GP to a secondary referral centre in London, which specialised in WM. So I was sent to, I had MGUS, so I was sent to Queen Square. And I've been managed at Queen Square for most of my care. And I was treated with IVIG, which is a monoclonal antibody. And what they weren't aware of is I had renal impairment and had renal failure. And so from that, after being investigated for the renal problems, it was picked up that my paraproteins were abnormal, and I had a bone marrow biopsy at that point. So it was quite a few years after I was first ill. I was then treated for Waldenstrom's with steroids, and I was starting to get a rising paraprotein. And there was a lot of talk about, should I have chemotherapy, should I have rituximab and all this sort of thing. And I had a nerve biopsy, which showed that my nerves were dead, and that if I had chemotherapy, it wouldn't bring back my neurological function. And so I'm now on watchful waiting, and my paraprotein has stayed at 8 since I had that initial IVIG in 2014. So it's sort of, I'm in that stage where, monitored regularly, which is usually can be 6 months, 10 months, depending when I can get an appointment, and then followed by my GP in between with renal function. So that's my story, my history. But the physical long-term effects of my MGUS Waldenstrom's is that my paraprotein is damaging my nerves. So what it does is a bit like a wire. When you have a cable, electrical cable, it has that sort of plastic wire around. It's stripped off the myelin sheath, which is the sort of covering of the electrical cable. And so I've got sensory nerve damage in the areas that are shown in the picture. I have one leg that is up to my knee, and one leg where it's just up to my ankle, and my hands. So I have unusual sensations. So sometimes I feel like things are really hot and they're not. So I've often picked up things thinking they're boiling hot. My hands hurt when I touch things sometimes. I have numbness, tingling, and I have balance problems. I also have muscle cramps, and I wouldn't call it twitching. I would say it's more of a tremor. So it's sort of goes also with reflex abnormalities. So I've lost all my lower foot reflexes. So I don't have spring. So it's very difficult to run, skip, and takes quite a lot of effort in terms of thinking about sort of managing stairs and steps and things like that. So when I was first diagnosed, I really struggled with getting across London, couldn't use escalators, found, traveling on the tube difficult, and felt quite disabled by it. The other physical effect I've had, which I was not so aware of, is that it's made me prone to infection. And although I've not had rituximab, because of the paraprotein and the bone marrow damage, basically I lost immunity to certain viruses. And so I've had to be quite cautious on infection. And since I was diagnosed, I've had sepsis. And I've had, in the first few years, I'd have shingles at least 10 times a year until I paid for a Shingrix injection. And I've been reasonably clear the last year and only had a couple of incidents. So I'm not that ill. Most people wouldn't even know. So when Beth contacted me, because through the Nursing Association, I'm a late effects expert, Beth didn't even know I was a Waldenstrom survivor. But it's the sort of thing that most people don't know because you have no outward signs. It's more sort of neurological. But what I found was, sort of going back, was when I was in hospital, there was a guy opposite me in the bed. I was treated as an inpatient because of the IVIG. I had a reaction, and he was being treated as well. And he actually was working on this program, the English National Ballet, Dancing for Parkinson's disease. And he had the chronic peripheral neuropathy. And he said, did you ever do ballet? Because I said, oh, I can't play hockey anymore. I used to do competitive hockey and all this sort of thing. And he said, oh, did you do ballet? And I said, yeah, as a kid, you know, up to teenager. And he said, go back to ballet because the exercises you do in ballet give you muscle memory and can improve your physical function tremendously. And the evidence from the research on Parkinson's disease is that it actually improves the fluidity of movement and it develops that what's called postural stability. Now, one of the things is I was working in rehabilitation science in the radiation effects, and we had exercise specialists and people who are working in exercise. And so I talked to them and joined a ballet class and sort of tested it out. And because you hold on to a bar, it felt very stable. And so I then have been doing ballet for nearly 8-9 years now. And it's helped with that postural stability, and it gives me confidence to be able to walk normally, feel that flexibility, but also that fluidity of movement. Haven't got rid of the tremor, but also the mindfulness of dancing and improving that sort of trying to remember dances, that sort of thing. And it's also been good fun. But there's also been research done in chemotherapy-induced peripheral neuropathy, looking at tango and ballroom dancing, and that the paper on the left by Nelson is about tango, and they've been using it in the States to try and improve sort of dancing, using dancing techniques to improve people's stability in terms of the neurological damage. I always thought that my neurology got better, but when I've had formal assessments every 2 years at Queen Square, my neurology is exactly the same. My nerves haven't grown back, but my confidence in what I can do has helped. So this is me. I don't know if you can see me here laughing, but this is at an end of a ballet where we were, I was in the corps de ballet. Hopefully, gladly, I was at the back. But, you know, that I've never thought I could have done something like that. And ballet isn't for everyone. I'm not saying that's something to do, but we know from a lot of studies that exercise is really important, improving muscle strength and also improving that neurological ability through resistance training and repetition. So if you have something you love, have a go at it because it really did help. Social and work-related effects have been not substantive, but I actually retired at 60 because having a tremor, and we use computers a lot, and everything's got tick boxes. And if you have a tremor with a mouse, and I was always like clicking the wrong boxes, and you're trying to mark scripts and things as an academic, that I just thought, why am I doing this? You know, I might as well retire at 60, work where I want to work. And I moved to Trinity College in Dublin. where I work on some of their late effects research and support students at Trinity, although I live in the UK. And but it's socially, it can be difficult, especially at night. I don't know if other people find this, but I use my eyes a lot to actually know where I am in time and space. So, for example, if I was in the dark, I can't see where my feet are. I can't tell what the floor depth is. So I tend to hold on to people. And I have actually at occasions or at a station where the floor is black and I can't tell the floor depth. I actually gone up to someone and said, do you mind if I walk across the floor with you? Because I can't tell where the floor is, which always seems really strange. But socially, going out at night, I find quite difficult. Empowerment is the other thing that really helped me, was that I was lucky enough that I can look up the papers. I did a review. I found a really good systematic review of what, some of the sort of initial guidance and what Waldenstrom's was. And I printed it out and I highlighted the section that my GP needed to do, which was monitoring my renal function, and also redoing my vaccination schedule. So I gave him this systematic review with the highlighted sections about what was important in terms of my monitoring. But what I found is that there's very little guidance on rehabilitation. There's no guidance on anything to do with like peripheral neuropathy. It's very much looking at your paraprotein. And if your paraprotein goes above 30, you have chemotherapy. And it's very difficult to know when sometimes if you have a symptom, is it related to your cancer or is it not related, or is it something different? And I always find it's quite difficult to keep the regular appointments because they never have space for the 6 monthly follow-ups, and you end up like, I did have shared care with hematology, and I'd end up with both my appointments for the year in 1 week. Because they like cancel, move it, change it. So I've had to be really rigorous at actually keeping an eye on my own paraprotein. And I use my kidney function as a surrogate for whether my paraprotein's going up. So if my paraprotein goes up, my kidney function goes down. And so I know, even though my GP doesn't do paraproteins, whether I'm actually going up or down. And I've sort of got used to it. It's me, doesn't define me, and still work, do stuff. But I feel that actually taking a bit of control, knowing what I can do, has been helpful, and having a way of contacting people in the hospital has been useful. I've not ever seen a specialist nurse. I've never seen a physio. Queen Square is very different from the sort of Macmillan services and stuff like that, but they do a good neurological assessment, but you don't get that psychological support or that access. But I could walk up the road to University College and go to the Macmillan Centre, but also I don't feel I need it at the moment, but I know it's there, and that's helpful for me in terms of anxiety. And this is this new roundabout in Birmingham. I don't know if you've heard about it, but I feel like Waldenstrom's a bit like this, which is this is a roundabout where people and bikes are prioritised. So basically, the red is the bike lane, and cars have to stop for bikes and pedestrians. And I looked at this and thought, it's a bit like Waldenstrom's, which is the cars are the treatment. So the treatment is prioritised. But actually, the ring road and round is really us. And really, very little is asked of the patient in terms of how they're feeling in any detail, or whether you're having, what's the guidance in terms of improving your peripheral neuropathy. And you have to find that yourself. And I think that we need a little more of the red in a way, to actually guide us much more. And I was thinking, if I came across this roundabout, I wouldn't know what to do at the moment, because this is such a new concept. And I think Waldenstrom's a bit like that, because there's so little information available on what's the best approach to manage like the peripheral neuropathy. How do you manage problems? What are the things you should be doing? And I think there's a lot we could do. So that's me. I'm going to stop sharing so it leaves enough time to have a discussion. And I hope that was helpful in a way. I feel very lucky. I have colleagues like Diana who I can phone up and ask questions, but also students who work in haematology and people who I can ask for things, and I can look things up myself. So I'm not what I'd call a typical patient, but I hope that my experience has been helpful.
That's fantastic. Thank you, Sarah. So we've got plenty of time now for any questions, or if anyone wants to share their experiences of any late effects of WM or which treatment that you've had to experience and had to manage, then that would be fantastic as well. So does anyone want to kick off with a question, either for Diana or for Sarah?
Hi, Beth.
Oh, hi, Robin.
It's our Stuart.
Stuart. Oh, go ahead. Sorry.
Not to worry. Yes, what are the late effects? I thought it was going to be saying, are the late effects of these treatment fatigue or white blood cells or whatever it is? I was expecting to know what the late effects are.
So Diana did do a little overview. One of her slides was about some of the late effects. I don't know if you want to give another little overview again, Diana. Sorry.
Yeah, I'm happy to share the slides, and they'll be Stuart. They'll be at the. I think it's being recorded, so you'll be able to see the slides if you want to see them again. So, so I think we talked about. We did talk about the peripheral neuropathy, and the different treatments will cause different effects. I think sometimes it's difficult to delineate between disease effects and treatment effects. With Waldenstrom, Sarah has described a lot of the disease effects, and then the treatment effects will really depend on the type of treatment that you've had. So, for example, I think we talked about rituximab, for example, can mean that some people's immunity can be compromised and make them prone to pick up sort of very grumbling infections and so on. So that's an example, but it depends on the treatment really, and there's a different kind of risk profile for the different treatments.
Could I just say, to add to that, Diana, is that with rituximab, it basically wipes the slate clean of a lot of your vaccinations. And so you need to make sure that you have non-live vaccines when you have your vaccinations, but you need often to be revaccinated after your rituximab has finished, because a lot of your prior vaccinations, so things like shingles vaccines, shingles is quite common after rituximab, so you often need to have any vaccines redone.
Thank you, Sarah. Diana. Robin, you've got your hand up. Did you want to ask a question? Oh, you're still on mute, Robin. Sorry.
My experience so far has been very similar to Sarah's, starting with MGUS in 2012-ish and having rituximab in 2018, and again at a more frequent dose rate in 2022. Subsequently, I've come to the conclusion that following that, it appears that I've suffered further nerve damage in my legs, which now cause my feet to drop and make walking very difficult and dangerous. However, it seems to be very difficult to distinguish between the sort of neuropathy that's a direct result of the Waldenstrom's with the paraprotein damage and what may be post-rituximab damage. Yeah. Can you shed a little light on that, please? And there is also another question that I want to ask, having found a paper on this relating to possible treatments.
Yeah, I don't know that we can actually, Robin, delineate between the disease effect and the treatment effect. So I think I'm going to disappoint you because ultimately it's resulting in that neuropathy and actually it's the impact, the joint impact of those. And sometimes we're just unable to delineate between those two. I think Yeah, I think this is a growing area. We don't know enough, and there's not been enough research about this, and there's certainly not enough care pathways to support. But I think Sarah gave some good examples. I mean, I'm not so sure she's suggesting you do take up ballet, Robin. But maybe Sarah wants to come in there about the research elements.
Yeah.
Well, that's interesting, because I did take up boxing, which is sort of similar, but I was unable to do it because of the problems I had with the balance. The idea again with boxing was development of stamina, strength, and coordination, but I just couldn't do it because of my feet.
And Robin, there is a slight delineation between the disease things of MGUS, because it demyelinates, the MGUS does. Whereas if you had bendamustine or rituximab, what it does is it affects the inside of the nerve. And so it's slightly different in terms of its impact. But things like, we know from chemotherapy-induced peripheral neuropathy that things like acupuncture do help in terms of the peripheral neuropathy, but also getting some physiotherapy for your feet in terms of exercises like sort of resistance training can improve the muscles in terms of muscle memory, because you don't always lose your muscle, you lose the sensation in your feet. And so you can often improve that afterwards. So you can improve your chemotherapy induced peripheral neuropathy up to a year after your treatment. So don't give up hope. It's something that if you can work on it, it does improve.
The other issue, and I may have got the word wrong, so as I don't have a background in neurology or hematology, please forgive me, it suggested that plasmapheresis has worked well on some patients. Does anybody have any information about that?
I can talk on that as well. Is if you have a high paraprotein, then plasmapheresis will reduce the because it's basically the paraproteins like little nibbling away at your nerves. Whereas if you have a fairly stable paraprotein after your treatment, it most probably wouldn't affect your neurology. A bit like me, the damage had already been done. So it's a matter of like improving what I had to actually try and maximize what I could do. So it maybe seek some physiotherapy advice, and also maybe have some acupuncture to help, because that reduces the peripheral neuropathy from chemotherapy in terms of the pain and any discomfort that you get.
All right, thank you. Thank you very much.
Okay, thanks, Robin. Beverly, would you like to ask a question or share an experience?
Yes, I was very interested in what Sarah was saying. I actually live in Canada now, but I was diagnosed and treated in England, and I was also at Queen's Square and at Macmillan too at UCLH. I started out with peripheral neuropathy, demyelinating with anti-MAG, and I was being treated for that before I found out I had Waldenstrom's. I also had Bing-Neill. And my neuropathy has got a lot worse. I have muscle wasting. My hands particularly are very, very bad, but my balance is bad. So I was very interested in the ballet, because I can't imagine being able to dance. Never mind about ballet. So that really perked my interest.
Yeah. We have this.
How you do that?
We have this thing in the UK which is called silver swans, and I think they have something similar in Canada. And basically, in our silver swans, we have people with knee replacements, hip replacements, very elderly. In my class, there's somebody who's 78. I'm in intermediate advanced, but I don't do point class now. But I started where I couldn't let go of the bar. And then I've just gradually built my strength up, and they do it very slowly. And the Parkinson's one, they do it from chairs. So you may be worth having a look. I'm not saying it's a sort of panacea, but if you can build your muscles back, your muscle memory does come back. Even if you can't feel things, it gives you that strength. If you do fall, you're not going to hurt yourself.
I did actually try the Silver Swans. It was during COVID, and they were doing it on Zoom. And I gave it up because I thought this is ridiculous. There's no way I can ever do this. But you've given me inspiration. I'll check out and see if I can find something here. But thank you. I really appreciate that.
Thank you, Beverly. Catherine, would you like to ask a question?
Yeah, I was just wondering whether anyone has any experience of skin issues after treatment. I finished my treatment at the end of October, and I've been plagued ever since with an itchy rash. Seen the GP, had antibiotics, steroid cream for a couple of weeks. I've had a referral to dermatology at the end of December, but that could be goodness knows when. And even going private, the first appointment I can get is April. I just wondered if anyone else had any skin issues after bendamustine and rituximab, and if they could offer any
Rituximab
advice.
does give you skin rash, is one of the side effects on the list. So it might be worth having a bit of a search on the American site to see what they do for that. I don't know, Beth might have some ideas as well, but it's quite common after rituximab for a period of time. Diana, do you have any?
No, I'm definitely not an expert in your treatments. That's the issue. Just more generic. So I'm actually just looking up Dr. Google myself. But I'm completely agreed with you, Sarah. I think you've knocked it on the head. Really, it's just that's very, very common, and it's just looking like there's other issues as well with the actual disease rather than the treatment too. So there are a number of reasons why it might cause that. But yeah, definitely it's not that I can contribute to this particularly, but I think what it's showing is system problems in that these are relatively common and we should be monitoring them, and you shouldn't be having this problem of access and having to go privately and still waiting a couple of months. I mean, you know, on the NHS, we should be monitoring your, I mentioned in my talk about EPROMs and how we can remote monitor for your symptoms so you can get straight in there and have your symptoms dealt with more promptly and more appropriately. So whilst I can't comment particularly on these medical issues that are very specific to your condition, and Sarah is doing a fantastic job with her experience, I think there are issues that the charity can, and Beth I'm sure is noting, where we really need to push for more responsive, supportive care for you, really, Catherine. That would be and I don't think you're alone with that.
But to be fair, I mean, my haematologists have re-referred me to dermatology, but it just goes through a standard, referral procedure. So I'm just trying as many creams as I can and taking fexofenadine to, get rid of the itching a bit. She says, scratching herself, thinking about it.
Yeah.
Thank you.
I was just going to say, a lot of people, and you can see in the chat as well, have a lot of skin problems after chemo, and some of it, like, there's a variety of things it could be. Some of it is dry skin, so different moisturizers can help, but obviously you've tried that and it hasn't helped. Steroids as well can, with some of the treatments for WM, can cause very fragile, friable skin. WM itself can cause lots of skin problems, things like Schnitzler syndrome. I don't know if many of you have heard of that, but that can cause like high V skin rashes. Cryoglobulins as well, those can cause skin ulceration in cold weather with your hands and feet and ears and things. Also, someone mentioned in the chat, which is a really good point, that cotrimoxazole, one of the preventative antibiotics they often give with chemo and for a few months afterwards, can cause a rash. But I'm sure your haematology team, Catherine, would probably have thought of that already by now.
Well, funnily enough, I didn't have cotrimoxazole because I'm allergic to it. So I had Dapsone instead, and they thought maybe that was causing the rash, so I stopped that, but it didn't didn't help. But no, so maybe I'm just an allergic type.
A sensitive flower. No, you're definitely not alone. I think there's loads of different reasons why people have skin problems afterwards, but it is very common. But I think what Diana touched on, that, you know, it's really showing a gap in care for people with WM having late effects after treatment. And the thing that Diana shared about the work that she's done with myeloma patients, she did that work with clinicians, doctors and nurses, but also with Myeloma UK, which is a charity, national charity. So, you know, we've been having a think as a charity whether we could do something similar and help develop some guidelines of how you can be looked after after chemotherapy and after treatment, and how late effects can be managed and monitored better, because, you know, if anything, this has demonstrated that there's a big gap there. So sorry, Diana, go on.
Yes, I think that's a really good point, Beth. I really think, you know, if join forces together and lobby for that. And I said that's research study that we did, it's a good 12 years ago, we got that funding. It really was not a big, expensive trial. I'm just responding to one of the questions in the chat, if I may, and that's about, I've just seen it. Robert Humphreys has said, would it be possible for WM UK to collect data on side effects? So so in Sheffield, there is a big clinical trial going on, being funded by Yorkshire Cancer Research. It's actually partly a national study. They're setting up a big database for immunotherapy toxicities, so people who have immunotherapy for different cancers, and they're collecting that data. So although rituximab has been around a long time, it's sort of part of a body and growing. There's different types of immunotherapies, but they're beginning to start to collect that data, and actually, you know, it needs to be very powerful and lots of data. So I think that is coming, and I think then they can break that up by treatment type and also by primary disease, to be able to inform that research. So hopefully that will come, but certainly I think it would be worth the charity just finding out whether they can influence that, and because you are such a small group, sometimes you're forgotten, and I think it would be important to make sure that you've got a voice.
Oh, thanks, Diana. And George, sorry, you've been waiting very patiently to ask your question.
That's fine.
It's
really
echoing a little bit, George. Sorry, it's just a bit difficult to hear you.
What I've got to do. I think it's because you've got that on as well.
What you want to do?
I can't change it. Let's move this one. Is that better?
No, it's still quite echoey. Can you try asking, and we'll see if we can understand.
Well, it was to say, if you are suffering from drop fluid, which I am, I've got demyelinating sensory neuropathy. Ask your GP to get referred for orthotics.
Okay, thank you.
Orthotics have been a lifesaver for me.
Oh, thanks, George. So for anyone who didn't catch that, George has been suffering from drop foot because he's got demyelinating peripheral neuropathy, and he asked his GP to refer him to orthotics, and that was really helpful. He said it was a lifesaver. So thanks for that, George. So we're running out of time. Unfortunately, both our speakers have to shoot off at 8 o'clock sharp. So I'm really sorry for people who've asked questions in the chat. We haven't had a chance to ask them. I'll take a note of them and see if I can get some answers to you. So I apologise if you haven't had a chance to have your questions answered. But thank you so much to Diana and Sarah for joining us tonight and for giving up your free time. I know Diana's been up since 4 this morning. you know, Sarah's very busy as well, so we really appreciate you both coming and speaking to us. It's been fantastic to hear both your perspectives, and thank you everyone else for coming and for participating. It's been a fantastic discussion. So our next webinar is on the 5th of March. We'll be joined by Dr. Jamal Kathari, who's a WM specialist consultant, and Harriet, who's a WM patient, and they'll be talking about clinical trials. So watch out for the registration details on our website. That'll be on the 5th of March. And thank you everyone again for coming.
Thank you.
Thank
Lovely
you.
to
Thank
meet
you
you
very
all. Thank you.
much.